Welcome to the Neurology Live Mind Moments podcast. Tune in to hear leaders in neurology sound off on topics that impact your clinical practice. I'm your host, Marco Meglio, editor with Neurology Live. In this episode, Dr. Julie Kurek, Associate Professor of Neurology at Augusta University, joins us to discuss how clinicians can differentiate dyskinesia from tremor in patients with Parkinson's disease. She breaks down key bedside features, including movement quality, rhythm, and distribution, and explains why these distinctions can sometimes be challenging in real-world practice. Kurek also highlights the role of medication timing, particularly levodopa, as a key factor in identifying dyskinesia, along with common diagnostic pitfalls and the importance of recognizing patient-specific patterns. The conversation also touches on emerging tools like wearable sensors and adaptive deep brain stimulation, as well as practical strategies such as video capture to better assess symptoms over time. Let's dive in.
Looking at the patient, I would say the main difference in the movement is the quality of the movement. So a tremor, you expect it to be rhythmic and stereotyped and sort of regular. And it usually affects a particular part of the body. For example, Parkinson's usually, it starts asymmetrically. So you might just have tremor in the right hand and the right leg, perhaps. So it's a little bit more contained. And dyskinesia will have a different quality to it. It's more Kurek, which comes Korea from the Greek for dance. So it's flowing, dance-like, and irregular. And while there can be some overlap of body parts, there is some difference. So like I said, the resting tremor of Parkinson's is stereotypically known as pill rolling, so more distal in the hand or the wrist, whereas dyskinesias can affect the face, the head, and the trunk, and have this kind of more unpredictable, flowy quality to it. So patients and I speak the same language. I usually put up as a poster boy Michael J. Fox, because you usually don't see him shaking, but everyone knows his sort of like random kind of movements, which is picture kind of poster dyskinesia. So it kind of gives a point of reference that people quickly recognize and can report. And it's easier, at least for me in clinic, to differentiate. And I'm sure we'll get to that point later. But sometimes what a patient reports as tremor and what they report as dyskinesia is two different things. So I always say, really take what they're reporting, because it's not their job to know the vocabulary or what's going on, with a grain of salt, and try to like tease out. So just phenomenologically, just kind of, I would say, the quality of the movement, regular and rhythmic and sort of stereotyped and affecting certain predictable body parts, whereas the other one is more random, flowing, different body parts, and a little bit unpredictable.
Yeah, I'm sure from a patient's perspective, they might think they have one thing and it actually might be the other thing on the other end of side of things. So you talked about the kind of quality and the difference between
Right.
dyskinesia and tremor. So how do things like timing and context, such as the relation to medication dosing, help kind of distinguish levodopa-induced dyskinesia from other various tremor phenotypes?
That's a great question. And that's actually one of the key anchors I use to help distinguish. So without medication, without having some levodopa or say any kind of stimulation, whether it be DBS or otherwise, you do not expect a patient to have any dyskinesia. Okay. Also, dyskinesia, if I, for example, took levodopa, I wouldn't develop dyskinesia. So dyskinesia is a phenomenon that happens when you have levodopa meets a Parkinson's patient whose receptors and dopamine system is sensitized differently. And levodopa has a predictable onset of effect time-wise. So a lot of patients will say it takes anywhere from 30 minutes to an hour typically to kick in. What we call kicking in is when the medicine's working, you start to notice the symptoms kind of melt away and they feel better. And usually the peak kind of concentration occurs 90 minutes after taking the medication. So if you're wondering if this is dyskinesia or tremor, and it can be tricky, even for an experienced clinician, because that same limb that has that sort of regular rhythmic movement, as the medicine turns in, it has this weird kind of transition limbo period where it's the tremor, you can see it turns into a dyskinesia. You can see the quality change before your eyes if you catch them in that window. So figuring out the timing. So if they're having something and you're not sure and it's been 90 plus minutes, it's probably dyskinesia. That's called like on or peak dose dyskinesia, which you can see with levodopa, but also in combination sometimes with DBS stimulation as well. And I would say 90% of the people fall into that. So most of the time, it's one of those things where it's easy until it's not. And that's where we run into a second subset of folks. Those are like 10 to 20% of people who tend to be more younger onset and women who don't read the textbooks and present a little bit differently. And they have something what we call biphasic dyskinesias. So what does that mean? So you see this hill, like the peak of that hill when the levodopa is at its peak is kind of when most people have their dyskinesias. With biphasic, what happens is the dyskinesias occur as the medicine is kicking in on the upward slope of the curve, not necessarily at the top. And then as the medicine wears out, that's the other time it happens. And when it gets tricky is trying to figure out, is this a biphasic dyskinesia, which in young women can sometimes be a dyskinetic dystonia, where it's not necessarily that flowy, but sometimes an abnormal contraction of the muscle. So either we're looking at a dose failure where somebody took their Cinnamate one morning and they took it with a scrambled egg, and so it never really kicked in because levodopa and protein compete for absorption. So yeah, that's something you want to advise people is that if you're going to have a protein heavy meal, either take your medicine 30 minutes before that meal or an hour after that meal. Usually carbs is okay. But if they've taken their medicine and you can see like this dystonic interning of the leg and they're complaining about some pain, sometimes it's hard to tell whether that's an off, because you can also have dystonic off and you can have a dystonic biphasic phenomenon. And those are the ones that I would say are tricky. And what you're going to want to kind of figure out is the pattern over the time, because we have to remember when we see that patient in front of us that day, it is just a snapshot, right? And their life is a video. And we're just seeing this for this one moment in time, whereas they may be living in a different state more often. So that's just something always to kind of keep in the back of the mind. And as neurologists in general, we're all about pattern recognition and pattern recognition over time. So really taking the time, I would say, one, to have a common language to educate your patient about what is on time, what is off time. Asking them, if you're not clear, maybe to keep a diary of when they're taking their medication and when they're having certain symptoms, and seeing the timing relation, right? If you look and consistently somebody at around 90 minutes are complaining about these weird movements, or they say my tremor is getting worse when I'm taking my meds, then you have an idea, okay, this is probably dyskinesia. And what we need to do is, rather than increase the medicine, which would make that worse, we probably want to like pull back, and that movement would then, ameliorate.
Wow, great breakdown on some of the small differences, for patients. I'm also curious, you talked about that pattern recognition. How, as a clinician, how difficult is it to kind of get an understanding of what a patient's pattern kind of may be? And, how can you kind of identify that early in some of those early conversations, despite the fact that you haven't had that long history of knowing that patient for so long per se?
Most people, when you say, when you take your medicine, you ask kind of like what changes. And they say, I feel looser, I feel more awake, or my tremor like subsides. And then you're like, okay, so that's your on state. Now, some patients may deny having an on state. So that's one of two possibilities. One, they never reached a threshold of medication high enough to actually reach that state. So you can never turn off or on if you're never given that kind of opportunity. The other thing is that, not to get too much in the weeds here, but you could be dealing with one of the atypical Parkinson's or Parkinson's cousins. And that you'd kind of figure out by just doing a trial and really increasing it and giving them the best chance to respond. But if they're not turning on and they're not sure, and you're pretty sure it's not an atypical, you've ruled that out, then you may need to increase the dose. And usually early on, people usually follow the timing pretty well in terms of it kicks in its peak at 90 minutes and it lasts anywhere about like 4 hours or so. So if you're looking at those windows and you have that kind of space of time that you both kind of agree on and that pattern, it's easier to pick out. And like I was saying, sometimes just asking them between the first and the second visit to just kind of be aware of what's going on, keeping that pattern, keeping that diary. It's like when people keep a food diary, you don't realize how much you're eating till you're like forced to write every calorie down. You're like, wow, okay, I see why I might be gaining weight. So I think that would help. So once they understand what on is and it clicks, and then they can understand. And I think it's also helpful, and I always encourage people to bring a partner with them who can be more objective, because it's really interesting. The brain is fascinating, of course, that any neurologist will say that. It's the reason why we went into the field, but people don't know what they don't know. And I have lots of patients who come to me where they had a resting tremor and they were never aware of it. It never bothered them. They used to watch TV at night. They're sitting on the couch and their wife notices that their hand is shaking. Because it's not an action tremor, it actually goes away with action. It doesn't interfere with eating and drinking the way an essential tremor would. So a lot of people are just kind of agnostic to it. So the tremor doesn't really bother them. Whereas if they get dyskinesias and they're wiggling, it really bothers them and it makes them self-conscious, and they don't want to go to the store because they said, people think I'm crazy or I'm on crack or, what's going on. And that really bothers them. Whereas I have people on the opposite end of the spectrum where they're not aware that they're dyskinetic at all. They can be wiggling like they're dancing and they're just like not aware of it. There's like a disconnect between what they're feeling and what's going on. And some people prefer to be in the dyskinetic state because they're more on their ability to move. And I suspect that's like with Michael J. Fox, because sometimes you have to make those difficult choices of being less dyskinetic, but more immobile and stiff, versus having some of those wiggles, but being able to move better. And so I would say it's important as the clinician, not only to have those definitions, but to find out what the patient's goals are and what their preferred state is, because you might be chasing a tremor and making it go away. You think you've done a good job, but actually the person doesn't mind so much, and they would really mind if they get dyskinetic and vice versa. And as I said, some people are not aware that they're dyskinetic. The spouse can then provide that collateral data to say, well, this is what's going on. And I've heard just like the tremor bothered the spouse, sometimes the dyskinesias bother the spouse because, they feel self-conscious too if they go out together. So on the first visit, you can just find out a lot by just taking the time to dive into that a little bit in terms of just like, say, one timing interval. You don't really necessarily need more than that.
We're going to take a quick break from our conversation with Dr. Kurek to keep you up to date on the latest developments in neurology. Welcome to the Neurology News Minute. Here's what you may have missed since our last episode. First up, on April 9th, the FDA accepted Ultragenyx's resubmitted biologics license application for UX111, an AAV9 vector-based gene therapy in development for MPS IIIA, otherwise known as Sanfilippo syndrome type A. The agency has assigned a PDUFA action date of September 19th, 2026 for a decision to be made. And next up, days later, Roche announced that its Alexis neurofilament light chain test had received CE mark approval for detecting neuroinflammation in patients with relapsing remitting multiple sclerosis. This blood-based assay is designed to provide clinicians with a less invasive method to monitor disease-related nerve cell injury and support clinical decision-making. And lastly, on April 15th, the FDA cleared Kala's KIQ+, an updated wearable transcutaneous afferent patterned stimulation system for the temporary relief of action hand tremor in essential tremor and postural and kinetic tremor symptoms in Parkinson's disease. Developed by Kala Health, the next generation device built on the previously cleared Kala IQ platform incorporating new therapy modes and an adaptive calibration designed to personalize stimulation and optimize tremor control. For more information about these stories, head to neurologylive.com, or you can check out the corresponding link in the show notes. And now, back to our conversation with Dr. Kurek.
Well, no, I think you bring up a lot of good points. And obviously, I think that patient-clinician communication and that type of discussion is very, very important for these patients and the families. And I think you also bring up a lot of good points about, what a spouse and what a partner could potentially see that the patient themselves may not be seeing or recognizing as something that is significant and needs to be brought to their neurologist's attention. Dr. Kurek, you also kind of talked a little bit about some of the related syndromes, kind of Parkinsonisms and things of that sort. So, when you are going into the kind of, we talked a little bit at the beginning of our conversation about the diagnostic process, but for other treating clinicians, what are the most common diagnostic pitfalls or misclassifications that clinicians should be aware of when evaluating abnormal movements and things of that sort in patients with suspected movement disorders, or specifically those with Parkinson's disease?
I would say, kind of heralding back to that cautionary tale of young-onset Parkinson's patients, that their dyskinesias can be dystonic. So I did say that most of the time it can be Kurek and kind of flowy, but it can also present as muscle tightening, interning, and odd, positioning. And since it can happen as the medicine is just starting to kick in, not at the peak, and as it wears off, I would say those are the trickiest cases to deal with. And I would just reemphasize listening to the patient, really paying attention to the timing, and maybe keeping a diary. And that will really go a long way. And if somebody, you're normally thinking about peak dose and somebody's just not fitting the pattern, then that's the time to think like, oh, maybe we're dealing with something different, maybe something like biphasic dyskinesias here. I would say that would be the biggest sort of caveat.
Well, these are all good considerations, and obviously things that our clinician audience likes to hear more about, and some of the smaller things that they might be missing in that diagnostic process. Dr. Kurek, I have one last question for you, and thank you again for taking some of your time and lending some of your great clinical insights. The last question for you, we've seen this conversation come up more and more about things like wearable sensors, and biomarkers is obviously a big buzzword in neurology right now. So, what role, if any, do tools like wearable sensors or digital biomarkers play in this differentiating process? And just talk a little bit about what we've seen from this area over the last couple of years.
There's two promising areas here in terms of like both biomarkers and response. And I would say the first one is adaptable or closed loop deep brain stimulation. So with deep brain stimulation, you can think of it as a pacemaker for the brain. We use the same battery like for a cardiac pacemaker, and the wire, instead of connecting to the heart, then goes to an area of the brain that we've chosen, whether it be the subthalamic nucleus or the VIM or GPI. And what's interesting with these electrodes, normally they're emitting stimulation that interrupts the tremor signal and disrupts the tremor from occurring. But not only can these leads now emit stimulation, but they can also record. And they are in a key area of the brain where the brain produces certain frequencies that correlate with the movements. So, for example, the known kind of bad frequency is the beta band in Parkinson's, and that's associated with tremor and rigidity. And with closed loop symptoms, like normally what we have with the open loop is that stimulation it's turned on and it's set it, forget it, and it goes at that constant kind of volume, so to speak, or stimulation level the whole time. With the closed loop, what it does, it can detect, say, a gamma band when tremor is worse, and increase the stimulation at that point. And then once that goes down, the stimulation can go down. And likewise, just as there's a tremor frequency, there's also a dyskinesia frequency. That's a gamma frequency. So now you have a system that can stimulate more when there's a tremor and recognize it. And also we can see that. We can watch these patterns in our clinician programmers because we can download the data. And then once we maybe we start pushing it too much into a gamma frequency, it pulls back. Because that can be one of the things with DBS too, because nobody with DBS simply goes on just DBS. We usually do DBS and medication. It used to be sort of this almost like thing of honor that you could get someone off their meds with DBS. It worked so well. But we also found that a lot of people had a lot of apathy or worse than their apathy. And first we thought it was the DBS stimulation effect, but it's really thought to be from the withdrawal and rapid withdrawal and abrupt from these medications that do other things that have mood and cognitive effects that work in parallel and are not substituted by the DBS. So that's really cool. So we're just getting recording and pattern, but also responding to it in real time, which is really a cool thing, because when you have stimulation and meds, if they're both kind of peaking at the same time, it could be too much. And this allows this really nice kind of interplay over the day, whereas it can keep the patient like smooth. So they have less of those peaks and valleys. The other thing is the personal kinetograph. The PKG is like a smartwatch, wearable watch. We don't use them personally, but a lot of centers do. It's verified, have wonderful algorithms to kind of detect tremor and bradykinesia and dyskinesia. There are some, drawbacks. You can't tell the difference between different types of tremor, like action versus rest, and it won't capture dyskinesias in the face, where it can be commonplace, where you can see it. But it's a great substitute. Sometimes you have patients who are not the best historians, or they just don't know what they know. They're not aware. And some people don't have a spouse or a friend with them. And that really provides the clinician, someone who's just seen that snapshot in time, a broader picture of what's actually happening with them over the course of the day. And looking at this, I was like, it would be really interesting because you can get data overload too. For the everyday clinician, you're going in, you're like, I don't have time to look at all the information and about what's going on. But what's interesting is that this company, which I would say it's the most verified FDA clear on the market, was in October, just recently, 2025, acquired by a company called Empatica. And that is also a software wearable, but also AI company. So where I see this going now is that it's going to take this and it's also going to synthesize it into an easy to read report about these are the patterns that are going on and this is what you can do about it. So it's going to make it much easier and easier, I would say, for all neurologists, general neurologists, anybody to look at this and be like, oh, because that's what computers and those systems are great at, pattern recognition. Of course, they never substitute like the clinical nuance and everything, but it's a great additional tool. So I see that becoming more, and they're making smaller devices. They have one in Empatica, has something called the Mini-Me, and it almost looks like jewelry. It's really not, not necessarily an eyesore or something like that. So yeah, it'll be interesting, that's maybe like a couple of years down the line. I mean, I currently have patients with the closed loop DBS, so that's real time right now. So I think those are all exciting developments that just kind of enrich our toolbox and make it easier to know what we don't know.
Thanks for listening to this episode of the Neurology Live Mind Moments podcast. To support the show, be sure to rate, review, and subscribe wherever you listen to podcasts. And as always, for more neurology news and expert-driven content, visit neurologylive.com.